The fifth metatarsal consists of 5 anatomical regions: the tuberosity, the base, the metaphysis, the diaphysis, and the head. The tuberosity, also known as the styloid process, is the prominent lateral proximal projection. It extends laterally and plantally. The metaphysis transitions into the shaft, and the proximal fifth metatarsal articulates with 3 bones: the cuboid, the fourth metatarsal, and the fifth metatarsal base. The diagram divides the fifth metatarsal into zones corresponding to common fracture patterns. Zone 1, tuberosity, styloid process. Zone 2, metaphyseal-diaphyseal junction, true Jones fracture. Zone 3, proximal diaphysis, stress fractures. This classification is essential because each zone behaves differently in terms of blood supply, healing potential, and mechanical forces. The base of the fifth metatarsal is a complex anatomical region with multiple tendon insertions. The peroneus brevis tendon inserts on the dorsal lateral aspect of the tubercle. The peroneus tertius tendon inserts more distally at the metaphyseal-diaphyseal junction. These tendons exert significant pulling forces during dorsiflexion and eversion, and often contribute to fracture displacement. Functionally, peroneus tertius balances forefoot dorsiflexion forces, counteracting tibialis anterior. Peroneus brevis stabilizes the foot under the talus and prevents excessive inversion. A third muscle, the abductor digiti quintae, originates from the lateral plantar surface and courses along the base of the fifth toe. The drawing shows how the peroneus brevis and peroneus tertius tendons pull on the base of the fifth metatarsal. Their combined traction helps explain typical displacement patterns seen in avulsion fractures and Jones-type injuries. The lateral plantar fascia is also shown attaching near the tuberosity, contributing to both longitudinal and transverse arch stability. Damage to these ligaments or the peroneus brevis tendon must be avoided during surgical exposure. The lateral branch of the sural nerve also runs near the operative field. The photograph shows a lateral incision over the base of the fifth metatarsal. A hemostat is retracting soft tissue, and the surgeon highlights how close the sural nerve lies to the incision. This image emphasizes the importance of careful dissection to avoid nerve injury during fixation of fifth metatarsal fractures. Epidemiology. Fifth metatarsal fractures are extremely common, representing 69% of all metatarsal fractures. Historically, incidence was around 46 per 100,000 person years, with more recent studies showing 39% incidence in Zone 1 fractures, 8 to 15% incidence in Zone 2, true Jones fractures, and 20% incidence in Zone 3, proximal diaphyseal fractures. They occur more frequently in males for Zone 1 and more commonly in females for Zone 3 stress-type injuries. Mechanisms vary by zone: inversion injuries for Zone 1, adduction stress for Zone 2, and repetitive microtrauma for Zone 3.
Fifth metatarsal fractures occur most often through twisting injuries of the foot or from a fall from standing height. Although they can also occur with motor vehicle collisions, the majority are related to inversion-type mechanisms. A Zone 1 injury at the base of the fifth metatarsal usually results from an inversion load. Sudden inversion of the hindfoot tightens the lateral plantar fascia and places tension on the insertion of the lateral band of the plantar aponeurosis, which inserts into the proximal base of the fifth metatarsal. This tension can cause an avulsion fracture. Depending on the fracture quality and the mechanism, these fractures can be comminuted, or in some cases, the pull of the peroneus brevis tendon may further displace the fracture fragment. Zone 2 injuries are known as Jones fractures. They represent an acute injury caused by adduction of the forefoot, producing a fracture at the proximal metaphyseal-diaphyseal junction. The fracture propagates from the lateral aspect of the proximal metatarsal to the fourth and fifth articular surfaces. It can extend proximally into the metatarsal cuboid joint and exhibit comminution. This type of fracture is more likely in individuals with long, narrow, straight metatarsals combined with an adducted forefoot. There is also an association between zone 2 fractures and hindfoot varus, metatarsus adductus, and pes cavus. The third type of fracture pattern occurs in the proximal fifth metatarsal diaphysis and is considered a proximal diaphyseal stress fracture. These are relatively rare and appear mainly in athletes. The fracture occurs within 1.5 centimeters of the shaft. Repetitive cyclic loads, especially those seen in high-level athletics, are the primary mechanism, and the injury is induced by tensile forces resulting in microscopic failure at the lateral cortex. Continued loading propagates the fracture medially. These stress fractures have a higher likelihood of delayed union or non-union. Shaft fractures are also common and represent 20 to 25% of all fifth metatarsal fractures. Spiral fracture patterns are the most common. The typical mechanism is rotational force applied to a foot that is axially loaded in a plantar flex position. The usual method of injury is rolling over the outer border of the foot. An increasing number of fractures in older women has been linked to lower energy trauma and may be considered early fragility fractures requiring metabolic evaluation. About 6.7% of all fifth metatarsal fractures are distal neck fractures. Patients with fifth metatarsal fractures usually present with pain, swelling, and tenderness along the lateral border of the foot. They often have difficulty walking. Bruising may appear shortly after direct trauma. To identify injuries that require further imaging, the Ottawa foot rules can be applied, which are reported to be 100% sensitive and 79% specific for detecting fifth metatarsal fractures. Radiographs are essential in the evaluation of fifth metatarsal fractures. Standard views include AP, lateral, and 30-degree oblique. These allow assessment of shortening, deviation, angulation, and displacement. If clinical suspicion remains, but standard foot radiographs are normal, an AP radiograph of the ankle that includes the proximal fifth metatarsal is recommended, as this view can reveal an avulsion fracture or an avulsion located at the tip of the tuberosity. Additional imaging is sometimes required to evaluate intra-articular fracture lines or comminution. CT scans help confirm fracture location and involvement when needed. MRI is useful for detecting soft tissue injury and stress fractures, and point-of-care ultrasonography may be helpful to identify early periosteal reactions typical of stress injuries. The OTA-AO classification system can be applied to fifth metatarsal fractures and focuses on the fracture pattern, but is not commonly used. These fractures are labeled as 87.5 for base fractures, 87.5.2 for metaphyseal fractures, and 87.5.3 for distal segment fractures. The Stewart system is commonly used for proximal fifth metatarsal fractures, and it's based on the relationship between the fracture line and the articulations at the base. The Dameron classification focuses on the fracture line in relation to the parodius brevis tendon insertion and includes a three-part system. Lawrence and Bate created widely used classification dividing the proximal fifth metatarsal into three anatomic zones. Zone 1 corresponds to the tuberosity and includes avulsion fractures. Zone 2 represents the metaphyseal diaphyseal junction and includes true Jones fractures. Zone 3 is the proximal diaphyseal region and includes stress fractures. Torg modified the Zone 3 classification to help predict healing potential. Type 1 represents acute fractures without prior trauma and shows a narrow fracture line. Type 2 represents delayed fractures with widening of the fracture line, periosteal changes, and radiolucency. Type 3 represents non-unions with a sclerosed medullary canal and history of repetitive trauma. First, let's look at when non-operative management is appropriate. Non-operative treatment is indicated for acute, non-displaced or only minimally displaced fractures, especially avulsion fractures of the tuberosity, which we call Zone 1 fractures. It can also be used in acute Zone 2 fractures and in carefully selected acute Zone 3 fractures. Relative contraindications for conservative care are clearly displaced fractures, persistent non-unions, Zone 3 fractures with long-standing prodromal pain, and highly demanding athletes or very active patients. When we choose conservative treatment, the plan has to be individualized. We need to consider the exact location of the fracture, the pattern and amount of displacement, the patient's age, occupation, and functional demands. We also have to correct underlying metabolic problems, such as low vitamin D, osteoporosis, diabetes, or thyroid disorders, because these factors can delay healing, especially in Zone 3 injuries. For most proximal fifth metatarsal fractures, a non-operative strategy is safe, with a relatively low risk of non-union and fewer complications than surgery, at a lower cost. But the Rockwood text emphasizes that we should still differentiate carefully between the various zones, because the prognosis is not the same for all of them. Zone 1 injuries are usually extra-articular avulsion fractures at the tuberosity, often non-displaced. These can be treated successfully with simple, closed methods: a stiff-soled shoe, a cast, a walker boot, or an elastic bandage with protected weight-bearing. Union rates are good regardless of the exact device used. Non-displaced avulsion fractures of the tuberosity typically heal uneventfully within 3 to 12 weeks, and most patients have minimal residual symptoms by 1 year. In non-athletic patients, even displaced avulsion fractures or fractures extending into the articular facet that contacts the cuboid tend to heal well. Functional outcomes are often better when we use an elastic bandage, walking boot, or ankle brace with weight bearing as tolerated, rather than rigid immobilization in a short leg cast. Systematic reviews have shown that treating Zone 1 fractures with a boot or bandage gives better functional scores and lower non-union rates than casting. For athletes and young high-demand patients with avulsion fractures of the tuberosity, we still often start conservatively, but some prospective randomized studies suggest that percutaneous screw fixation gives better results when displacement is more than about 2 to 3 millimeters. Other options, like a distal ulna hook plate, have also been used. Interestingly, even for non-displaced Zone 1 injuries in athletes, a hard-soled shoe has been shown to be more effective than a short leg cast in a prospective trial. Now, we move to the more problematic area, the proximal metaphyseal diaphyseal region, especially Zone 2 and Zone 3. Acute injuries of the proximal diaphysis in Zone 2 are controversial. Meta-analysis suggests a trend toward better outcomes with operative treatment, with higher union rates and faster time to union, compared with non-operative management, both in athletes and in non-athletes. Part of the confusion arises because earlier serious mixed truly acute fractures with chronic stress injuries. Patients with prodromal pain before a fracture, typical of Zone 3 stress fractures, tend to heal more slowly and should be considered separately from acute traumatic fractures. For non-athletic patients with acute proximal metaphyseal diaphyseal fractures without prodromal symptoms, a non-operative regimen can be used. The standard is a short-leg, non-weight-bearing cast for 6 weeks. At 6 to 8 weeks, if the fracture was acute and there were no prior symptoms, we can move the patient into a removable short-leg walker, allow progressive weight-bearing, and start physical therapy. Most acute fractures treated this way heal within 9 to 10 weeks, and when the patient can walk and perform sports-specific activities without pain, return to sports can be considered. Stress fractures with a clear history of pain with activity are a different group. These are often left non-weight-bearing for an additional 8 weeks and then reassessed both clinically and radiographically.
Radiographs should show sclerosis around the margins of the fracture and evidence of healing, and palpation of the area should no longer be painful. Because the watershed blood supply in this region is poor, non-union rates for Zone 2 fractures after conservative treatment can reach about 21%, so surgery may be preferred in many of these cases. For incomplete stress, or Jones-type fractures, low-intensity pulsed ultrasound has shown some promise, but the data is still limited. Zone 3 fractures occur even more distally, beyond the proximal tuberosity, and often present as chronic stress injuries with prodromal symptoms long before a complete fracture. Acute Zone 3 fractures are rarely reported, but many surgeons treat them similarly to Zone 2 fractures. Because Zone 3 fractures have a strong tendency toward non-union, successful management usually requires a more aggressive approach, ranging from long periods up to 3 months of non-weight-bearing casting to surgical fixation with bone drafting and internal fixation. When we decide to operate, the workhorse technique is intramedullary screw fixation. To reduce the risk of implement failure and non-union, we have to be meticulous with reduction and compression at the fracture site. The screw diameter should be at least 4.0 millimeters and often between 4.0 and 6.5 millimeters, and we should use the largest solid screw that the bone can safely accept. Several CT-based studies show that a diameter greater than 4.5 millimeters is needed in most patients for adequate fixation, because the medullary isthmus is usually larger than that. Screw length must also be chosen carefully. If the screw is too long, it can displace the fracture, penetrate the cortex, or create rotational asymmetry. Different authors suggest keeping the screw length roughly 2/3 of the metaphyseal length, and certainly no longer than about 70% of the total bone length, with the threads just distal to the fracture. Common technical problems in the surgery: too long a screw, failure to tap, soft tissue interposition, or irregular fracture surfaces can all lead to distraction at the fracture site and non-union. Zone 2 and Zone 3 fractures in athletes are generally treated operatively to minimize time away from sport and reduce the risk of delayed or non-union. Intramedullary screw fixation is considered the gold standard, but there are alternative techniques: modified tension band wiring, hook blade fixation, plantar plate fixation, metatarsal biplanar osteotomy, and even many Ilizarov external fixation. In elite athletes, a systematic review of surgically treated proximal fifth metatarsal fractures showed a radiographic union rate of about 97%, with mean time to union around 9 weeks and the complication rate just over 20%. Return to sport rates for surgically treated Jones fractures approached 98% at an average of about 9 to 10 weeks, which is clearly faster than the roughly 13 weeks seen in non-operative care in meta-analyses. Orthobiologic adjuncts such as autologous bone graft, bone marrow aspirate concentrate, or demineralized bone matrix may improve union rates, but they don't seem to change the time to union or the time to return to sport. Timing of full weight bearing is critical. Starting full weight bearing too early and pushing for an early return to play can jeopardize healing. In one series of professional football players, returning to play earlier than 8 weeks after screw fixation was a significant risk factor for delayed union. Now, look at the image on the page. It shows a calcaneal autograft being harvested from the heel through a small incision. This technique provides cancellous bone graft that can be used for many foot and ankle procedures when only mild to moderate volume is required. The calcaneus is a convenient source of autogenous graft in the same surgical field. This is particularly relevant for the management of Torg type 2 fractures, which are delayed unions, and Torg type 3 fractures, which are true non-unions. These cases often require reopening the fracture site and adding bone graft. Bone marrow aspirate concentrate, structural bone graft, or a combination of both can be used. If non-union persists after initial operation, we should reassess the alignment of the foot and correct any misalignment that might be preventing healing. Finally, plantar plating submerged as another option, especially in revision cases for stress fractures of the fifth metatarsal. Placing a plate on the plantar or tension side of the bone may offer biomechanical and biological advantages, helping control torsional instability and preventing plantar lateral gapping by applying compression along the tension side. Studies show time to union and time to return to sport with plantar plating are comparable to other operative fixation methods in both primary and revision settings. For completeness, the text also comments on diaphyseal spiral fractures of the distal shaft of the fifth metatarsal. These distal injuries generally heal very well with conservative management using immobilization and functional weight bearing. In a series of patients treated with a protocol of weight bearing as tolerated in a cam walk or hard-soled shoe, functional results were excellent. Only a small percentage developed delayed union, and even these went on to heal by 6 months. On average, patients achieved pain-free walking, returned to regular shoes, and radiographic union in roughly 7 to 8 weeks.
Operative treatment of fifth metatarsal fractures is mainly reserved for situations where we want to speed up healing and guarantee reliable union. The classic indication is a highly active patient with an acute Jones fracture. Surgery is also recommended when displacement is greater than 2 millimeters, and for fractures that extend into the fifth tarsometatarsal joint, where open reduction is needed to restore the joint surface. Diaphyseal fractures of the fifth metatarsal shaft may also be fixed operatively, even with minimal displacement, to maintain an even weight-bearing surface across the metatarsal parabola. Contraindications follow the usual rules: poor patient condition, vascular compromise, local infection, or significant medical instability. Before surgery, there is a clear preoperative checklist. We need a radiolucent operating table because intraoperative fluoroscopy is essential. The patient is positioned supine or in a sloppy lateral position with a bump under the ipsilateral hip to help internally rotate the foot. Fluoroscopy is usually set up on the contralateral side. Equipment consists of small and many fragment implants, cannulated screws and K-wires, and a tourniquet is usually placed above the knee. The surgical approach is straightforward. The patient lies supine on the radiolucent table with the bump under the hip to bring the lateral border of the foot up. The mini C-arm can be at the end of the table, or standard fluoroscopy can be positioned opposite the foot. The incision is made along the lateral border of the fifth metatarsal, just above the abductor digiti minimi muscle. The key steps for open reduction and internal fixation are as follows. First, the incision is placed proximal to the fifth metatarsal base in the interval between the peroneus brevis and peroneus longus tendons. Second, a guide wire is introduced down the medullary canal of the fifth metatarsal under fluoroscopic guidance. In cases of delayed union or non-union at the base, the fracture site is completely open using osteotomes or a rongere so that all fibrous tissue and sclerotic bone can be removed. Any void or cortical defect created by this debridement is filled with autologous bone graft. The definitive fixation is then done with a cannulated or solid compression screw, typically 4.5 millimeters in diameter or larger, to snugly fill the medullary canal of the fifth metatarsal. As an alternative for base fractures, a many-fragment screw combined with a tension band construct can be used. For distal metatarsal and shaft fractures, a small fragment plate is often preferred. The text then details the technique in more depth. For intramedullary screw fixation, we first identify the tuberosity and the fracture or non-union. The skin incision is made proximal to the tuberosity, again between peroneus brevis and longus. A guide wire is introduced down the medullary canal of the fifth metatarsal under fluoroscopic guidance. In cases of delayed union or non-union at the base or the metatarsal shaft, the fracture is opened, fibrous tissue is excised, the medullary canal is cleared, and the defect is filled with autograft before placing the compression screw. The algorithm shown in the flowchart summarizes the author's preferred treatment strategy. All fifth metatarsal fractures are first divided into base fractures and shaft fractures. Shaft fractures that are diaphysio stress fractures are treated with a short-leg non-weight-bearing cast. Base fractures are subdivided into tuberosity avulsion fractures and Jones fractures. For tuberosity avulsion, involvement of less than 30% of the articular surface is treated with a rigid-soled shoe. When more than 30% of the articular surface is involved, open reduction and screw fixation are recommended. For Jones fractures, athletic patients are treated with intramedullary screw fixation to allow quicker and more reliable union, while normal or low-demand patients can be managed with a short-leg, non-weight-bearing cast. The radiograph labeled as figure 6845 illustrates tension band wiring for a displaced fracture at the base of the fifth metatarsal. The first image shows progressive displacement on an oblique view 2 weeks after the injury. The second image demonstrates the fracture after screw fixation and tension band wiring, with the fragments reduced and stable. Post-operative care follows a structured pathway. Because surgical stabilization does not allow an immediate full return to sport, patients leave the operating room in a splint that allows early ankle motion. Within about a week, this is converted to a CAM walker boot. After 3 weeks, low-impact activities like swimming and cycling are allowed. With partial weight bearing, the goal is to discontinue crunches by 6 to 8 weeks, at which point physical therapy focusing on gait and strength can start. At 6 weeks, healing is assessed, both clinically and radiographically. If consolidation is adequate, there is a gradual, stepwise return to full activity. The section on complications and pitfalls highlights some important points. For Zone 1 fractures, non-union can occur, but is often asymptomatic and may not require intervention. When symptomatic, non-union can produce lateral foot pain or TMT joint pain from nerve irritation. In those cases, the fragment is excised and fixation with cancellous bone grafting and a 3.5 or 4.0 millimeter lag screw or a hook plate is recommended. For Zone 2 and Zone 3 fractures, non-union and refracture are more often related to inadequate treatment, such as insufficient periods of non-weight bearing, poor surgical technique, wrong implant choice, inadequate grafting, or incomplete debridement of the sclerotic canal. Malposition of the screw can lead to unicortical gapping, delayed healing, pain, and even bunionette deformity from a normal shoe contact if the screw head is too prominent. Figure 6846 shows a typical problem case. A 25-year-old male football player had undergone intramedullary screw fixation for a 5th metatarsal stress fracture at another clinic 4 months earlier. The screw was malpositioned and the guide wire broke, and the fracture site had become sclerotic, corresponding to a TORG type 2 non-union. The AP radiograph demonstrates the non-union. During revision, the incorrectly positioned screw and broken key wire are removed under fluoroscopy, and a new incision is planned 2 to 3 centimeters proximal to the base, aligned with the 5th metatarsal on AP and lateral views. The final panel shows the 1-year follow-up after proper revision with a healed fracture. The table on common adverse outcomes and complications lists the main issues: soft tissue irritation from a prominent screw head, penetration of the screw into the distal cortices, delayed union or non-union, rotational or angular shaft deformity, and chronic low-level pain. Soft tissue irritation could usually be prevented by countersinking the screw head appropriately and considering hardware removal once healing is confirmed. Delayed union, non-union, and refracture are most often related to improper biology of the fracture, performing a meticulous debridement, using bone graft when indicated, and delaying full weight bearing until there is clear radiographic evidence of union.